Okay, we're going to get started, everyone. Welcome to our May Spark session. Just so you know, Spark is sharing periodontal advances in resident knowledge. And the hope is this that we can celebrate calibration, innovation, and shared learning among our periodontal programs. We have a special Spark session this month, and we're going to be featuring our military programs. So just so you know, Spark aims to showcase the outstanding work of our periodontic residents and their programs. It provides a national platform to share, discuss, and to learn. It encourages collegial interaction and the exchange of ideas, and we hope to strengthen the bridge between resident education and the professional growth within our AAP community. A few things I want to remind you about. We do Spark quarterly, and our next Spark session is going to be Tuesday, August the 11th. So go ahead and mark your calendars. We're working to get a time. Once that's available, we will start sending out information about it. But the topic is going to be functional crown lengthening for optimal restorative outcomes. And we're going to feature our East Coast programs, University of Florida, Medical University of South Carolina, and the University of Rochester. So please join us as we do that. Another reminder for our post-grad programs is that Arrive registration is now open. So please visit the website. We encourage all of you to participate in Arrive. It was a really great event last year, and the programs that did participate really enjoyed it. So I encourage all of y'all to go in and register for Arrive, which will be in San Antonio again. And like always, we do love our surveys, and I would like you to do a post-Spark survey. This Spark session will help us to get feedback because every time we get feedback, we try to make improvements to the session. So your feedback is very important for us. And then moving forward, we can incorporate those changes into the next cycle. And with that, we're going to pass it over to the true stars of this, our residents. And I'm going to introduce our moderator, who is Dr. Justin Galliani. He is a captain in the United States Army Dental Corps and a third-year periodontics resident at Fort Gordon. He was born and raised in California, and he received his DDS from UCLA School of Dentistry in 2020. He completed a one-year AGD program at Fort Bliss in El Paso, Texas, and was also stationed at Fort Meade, Maryland, prior to beginning residency. He will take on his next role as a periodontist in Fort Bragg, North Carolina. So with that, please join me in welcoming Dr. Justin Galliani, who will serve as our session moderator.
All right, thank you for that introduction. Screen looking okay? So I'm going to begin here. Good afternoon, everyone, and welcome to a Spark presentation by the AAP. For today's presentation, the AAP united three branches of our armed services, and we will today be hearing from the U.S. Army, U.S. Navy, and U.S. Air Force. Our discussion will be regarding sinus augmentation from evaluation to execution. My name is Justin Galliani, and I'm a third-year resident of the United States Army's Periodontics Program, led by our director, Colonel Thomas Johnson. Following is a disclaimer for the following three presentations. We have no financial interest to disclose for our lectures, and the opinions presented are our own. On our agenda today, I will provide a relatively brief introduction to sinus augmentation. From there, my colleagues will present techniques on both indirect sinus augmentation and direct sinus augmentation. At the end, we will have time for questions and answers. We will jump in first to discuss how patient history can impact a sinus augmentation surgery. We understand that one of our key deficiencies of hard tissue volume prior to implant placement is height of bone in the posterior maxilla. According to Hamid, the vast majority of the post-extraction alteration of the bone height is due to alveolar crest changes in comparison to the sinus floor position. Regardless, we must understand that a residual ridge height of 4 millimeters or less is found in almost half of first and second molar sites, and even more of these sites still will present with inadequate height for implant therapy. Particularly in the edentulous and elderly populations, almost 90% of these patients will have severe deficiencies in the posterior maxilla. All this is to highlight that sinus augmentation is not an option for us. It is a requirement in over half of the implant cases we will encounter in the posterior maxilla. Our initial exam is of utmost importance when it comes to sinus surgery. We have countless factors we must consider prior to surgery, and I will list out 6 here that can directly or indirectly impact our sinus augmentation surgery, whether by complicating the handling of the sinus membrane or decreasing the success of our implants. We will start off with an easy one. Smoking has been associated with increased complications and patient morbidity in sinus surgery. Smoking is one of the factors that most reliably leads to adverse outcomes, including sinusitis, perforation, and postoperative infections. If we perform any type of sinus surgery on a smoker, we must understand that the surgery will be more challenging and will likely have more postoperative complications. Diabetes significantly impacts overall wound healing, but this effect has not been consistently demonstrated in the implant literature. Multiple studies demonstrate high rates of implant survival, even in diabetics with up to 12% HbA1c. And within the realm of peri-implant disease, the effect of glycemic control has mixed outcomes. Some studies report minimal differences based on glycemic control, but other authors have found significantly worse peri-implant mucositis and implantitis in those who demonstrate poor glycemic control. In regards to sinus surgery specifically, glycemic control tends to be a strong predictor of short-term postoperative complications in ENT surgery. One study from Schashinger evaluated records from over 14,000 patients and found that worsening glycemic control correlated with worsened postoperative outcomes. Osteoporosis is a somewhat controversial topic in terms of implant survival, especially in the posterior maxilla with the least dense bone we have available. Systematic reviews indicate similar implant survival rates, although this may be partially attributed to careful exclusion criteria for severe osteoporotic patients. We must also consider with osteoporotic patients which medications they are on. If the patients are on high-dose or IV bisphosphonates, the risk of osteonecrosis increases so significantly that these patients may not be surgical candidates at all. And last, understand that anti-resorptive therapy can also affect implants that have osseointegrated. Monitor these cases carefully. Interestingly, a few comparative analyses have been performed on the effect of periodontal phenotype in relation to membrane thickness, and they have found that there is a significant correlation with one's gingival phenotype and the sinus membrane thickness. Additionally, this data tends to correlate with more favorable ridge height as well. This stands to reason, as we know that patients with thicker phenotype will experience less hard and soft tissue remodeling post-extraction. And we will talk a bit about the membrane in a few slides, but in these comparative analyses, a thicker gingival phenotype led to slightly decreased rates of perforation. Chronic rhinosinusitis can lead to a whole host of respiratory issues that we often do not have to deal with. In sinus surgery, however, the inflammation in the respiratory system is of our utmost concern. In one study, Kozuma et al. Found that rhinosinusitis led to increased infections and increased implant loss. Other authors as well note that the membrane in those with chronic rhinosinusitis can become more gelatinous and spongy, making the chance of perforation higher. The complexity of chronic rhinosinusitis is well beyond what we will discuss today, but I wanted to bring into our vision that the disease not only has downstream effects of promoting inflammation throughout our respiratory system, but the epithelial barrier itself is significantly impacted. Since this is the area we are handling, we must be aware of this impact. Finally, the presence of periodontal disease leads to significantly higher rates of periimplantitis, notably about 5 times higher rates according to Carusis et al. Interestingly, periodontal disease may also be correlated with a thicker sinus membrane. This is not universally confirmed, but may be a clinical factor to consider. And finally, stage 3 and 4 periodontitis, or significant endoperiolesions lesions that encroach upon the sinus floor, may lead to acute localized sinus inflammation. The Schneiderian membrane is another important factor to consider pre-surgically. It is composed of 3 layers, which include secretory cells facing into the sinus space, and a thin connective tissue layer fused with the periosteum, which is the tissue we will exclusively contact during surgery. Thickened membranes may be found in multiple types of patients, but the most notable quantitative correlations in a study by Monnier were on older patients, smokers, and those with thick tissue phenotypes. Overall, the mean thickness of the membrane tends to be just over 1 millimeter, and the CBCT often exaggerates the thickness by 2.5 times compared with the histological view, which shows under 1 millimeter of thickness on average. Additionally, one study by Lin found that the membrane thickness had a significant impact on perforation rates, but in a somewhat unexpected manner. They found that the membrane thickness with the least perforation was in the 1 to 2 millimeter range. In contrast, membranes thinner than 1 millimeter and thicker than 2 millimeters had similar perforation rates. This points to one idea that we as surgeons must consider preoperatively. Membrane thickness may not directly impact perforation rates. The reason for thickness, such as smoking, rhinosinusitis, or age, may indicate underlying pathologic changes to the respiratory tissue that can alter the malleability of the membrane. Now I want to touch on a few clinical factors that may impact sinus surgery, but this list will by no means be exhaustive. A CBCT should be obtained at any evaluation appointment for a sinus surgery. 3D imaging is critical to evaluate the complex anatomy of the maxillary sinus. We do not have time to touch on every point here, but I will introduce a few of these factors to consider in the clinical process. Two crucial angles that are relatively straightforward to evaluate on 3D imaging are the medial lateral wall angulation, labeled in A on the right diagram, and the palatal-nasal recess angulation labeled in B. The medial lateral angulation is most favorable as the angle increases, with acute angles of 30 degrees or less having the greatest chance of perforation. And palatal-nasal recess angles that are more acute also demonstrate increased levels of perforation. Those that are 90 degrees or more are considered most favorable for sinus augmentation. Sinus septae are thin cortical walls that protrude from the sinus floor and divide the sinus cavity. They are found in almost half of patients and 1/3 of sinuses. In preoperative surgical planning, septae must be identified on 3D imaging because they increase the perforation risk by 3 to 4 times in lateral window sinus surgery. Importantly, we can plan around these when we know they are present. Multiple surgical variations exist, including the bottom right image, in which a guided surgery allowed the surgeon plan 2 windows and work around a significantly large septum in the region. The blood supply to the maxillary sinus is provided by branches of the maxillary artery. There are 2 arteries that are of prime concern for us surgically. The infraorbital artery and posterior superior alveolar artery form a double arterial arcade that can sometimes interfere with our ability to access the sinus. Notably, the intraosseous anastomosis of these vessels was found in Solar's study in 100% of the patients and range from 14 to 25 millimeters superior to the alveolar ridge, averaging approximately 19 millimeters. And to corroborate Solar's study, one study by the Army's own Dr. Carson McDaniel was the first study that utilized CBCTs to evaluate the position of the vessel with the CEJ as the point of reference. His study had 2 primary findings. First, the mean distance from the CEJ of the posterior teeth was approximately 19 millimeters to the vessel. And second, that 3D imaging can be used to clearly detect the artery approximately 92% of the time. Finally, before I introduce our next speakers, I will briefly touch on the postoperative course for sinus surgery. When we elevate a sinus and place a particulate graft, what we will ultimately gain histologically is similar to what we see in alveolar ridge preservation sites. We will see a mixture of new bone, residual graft particles, and dense scar-like connective tissue interwoven. However, a study by Palma showed that with or without graft material, they found no difference in terms of implant stability, bone to implant contact, or bone area within the implant threads. Most infections originating in the sinus are viral in origin, but acute rhinosinusitis can be associated with bacteria, and they are most commonly the ones listed here: Haemophilus influenza, Streptococcus pneumonia, Moraxella catarrhalis, and Staphylococcus aureus. The recommended regimen for bacterial coverage during the healing phase is generally either Augmentin, which is a mixture of amoxicillin and clavulanate, or doxycycline in those who are allergic to penicillin. The reason for the addition of clavulanate is because these bacterial species found implicated in sinus infections may be variably resistant to amoxicillin alone. For example, amoxicillin was found to be ineffective in over 92% of Moraxella catarrhalis isolates. Even with antibiotic coverage, though, infections do happen. The primary factors that increase infection risk are listed here, and they are not unfamiliar to what we would expect. Most of these factors are patient dependent, but some factors are in our control as surgeons, such as membrane perforation and the lack of an aseptic technique. Sinus surgeries can be greatly impacted by the lack of using an aseptic technique to the point where some experts in our field recommend a separate set of sterile instruments utilized exclusively when the sinus is open. The best treatment for an infection is preventing it from happening in the first place. But postoperative infections will occur regardless of what we do, and we must understand how to best manage these complications. Initially, we must first know how to identify the signs of a normal versus an abnormal postoperative healing course. Typically, discomfort, swelling, and minor nose bleeding within the first few weeks may be signs of a normal healing course. On the other hand, acute, severe discomfort or the persistence of symptoms beyond 3 weeks is cause for concern and investigation. The first step in the course should be obtaining imaging, in this case, a CT scan. This can give a clear image of what is happening within the surgical site. Next, antibiotics are the initial treatment of choice. This includes adding metronidazole to the regimen of Augmentin or using levofloxacin in cases of an allergy to penicillin. However, extreme caution is recommended when using levofloxacin. Fluoroquinolones, such as levofloxacin, are extremely powerful antibiotics, but have a significantly increased risk of tendinitis and tendon ruptures, which tend to be even more elevated in elderly patients. Most of the time, an infection from sinus surgery is due to an infected sinus graft, not a true sinus infection. If this is the case, a partial or total removal of the graft is indicated. If the Schneiderian membrane is not intact and graft has extended into the sinus proper, then a multidisciplinary approach with ENT is recommended, which may include FES or functional endoscopic sinus surgery. As with most studies based on success, there are numerous systematic reviews with varying reports. What we generally understand is that success rates are very high for implants placed in augmented sinuses with either technique, but a slight edge appears to go to the transcrestal approach. Out of the failures documented, about 80% of them tend to occur within the first year. One interesting finding from a systematic review by Diaz-Olivares is that perforation did not appear to significantly impact the success of implants, at least in those that were perforated and repaired. In this study, 30% of sinuses were perforated, so this is an important fact to consider. All is not lost when a perforation occurs. During our short talk today, we have discussed the following key points. Understand that the success of our surgery begins with a proper patient history and initial evaluation. Next, our intrasurgical success can be determined by a number of factors that may or may not be under our control. And also keep in mind that our surgical technique is only one piece of the puzzle. Proper postoperative care is key for sinus augmentation, including an evidence-based antibiotic course for the patient. Now we will put what we know into clinical practice. I will hand off controls to our speakers who will touch on the transcrestal or indirect technique and the lateral window or direct technique. Our speakers for today consist of the following 4 officers. I am our moderator, Dr. Justin Galliani, Captain in the United States Army. Presenting the transcrestal augmentation technique will be Dr. Thomas Betterbed, Commander in the U.S. Navy, and Dr. Cody Clark, Lieutenant Commander in the U.S. Navy. And last, presenting the lateral window augmentation will be Dr. Tyson Chung, Lieutenant Colonel in the United States Air Force. And with that, I want to thank you for your time today, and I encourage everyone to ask questions in the Q&A section on Zoom, which you can find under the More tab during the presentation. So we will have a question and answer section at the end of this event. And with that, I want to thank you all for your time, and I will now hand off the controls to our team of Navy presenters.
Okay, thank you, Dr. Galliani. Can everyone hear me and see my slides? Okay. All right, yes, I'm Thomas Betterbed, and this is Cody Clark. We are second year residents here at the Navy program. And we're going to talk about the indirect sinus augmentation or closed or transcrestal approach. Today we'll review some indications and contraindications. We'll go over the original Summers osteotome technique, some modifications that have been made over time, and then we'll walk through 3 clinical cases demonstrating different sinus elevation or different sinus crestal sinus elevation approaches. How do we decide between open and closed? Primary determinant is the amount of residual bone from the crest to the sinus floor. We have a study by Rosen looking at the osteotome technique, found more predictability with those with 5 millimeters or more residual bone height. It had about 96% survival in those that were more than 5 millimeters and dropped down at 86% with 4 millimeters or less. We also need adequate ridge width and a general guideline that the amount of the vertical augmentation we attempt generally should not exceed the residual native bone height. So if we have 5 millimeters of residual bone, gaining 3 to 4 millimeters is typically predictable. Some major advantages include being less invasive, less patient morbidity, less post-op discomfort than lateral approach. It also allows for simultaneous implant placement, as well as we saw before, similar success rates to implants placed in the maxillary posterior. So despite its predictability, this technique does have complications, or it does have its own limitations. Primarily residual bone height of less than 4 millimeters, as we saw in the Rosen article. Those with active sinus disease or pathology, anatomical limitations like presence of septae, or very narrow ridges that would require simultaneous horizontal augmentation. Some disadvantages, there is a risk of sinus membrane perforation, although possibly lower than open lift. There still is reported rates ranging from 0 to 17%, as well as a unique complication of benign paroxysmal positional vertigo. Can occur from repetitive malleting with the osteotome and can dislodge otoliths within the inner ear. It is uncommon, the rate of about 2 to 3%, but it's important to identify these patients in the treatment planning process. Those with a history of vertigo can alter your choice in your technique. So this brings us to the original technique described by Dr. Summers in 1994. This was a major innovation because it offered a way for us to elevate the sinus floor without lateral access. He recognized 2 major challenges in the posterior maxilla. The first being that this region typically contains poor quality type 4 bone. And second, maxillary molars are frequently lost earliest in the mouth. This can lead to ridge resorption as well as progressive sinus pneumatization. So together, these factors make implant placement challenging in this region. So this technique, instead of rotary drilling to the final depth, he used progressively larger tapered osteotomes inserted with gentle mallet. This achieved 2 things: apical bone displacement to elevate the sinus floor, as well as lateral bone compaction, which improved local bone density. Originally, this technique was used only with autogenous bone collected with the concave tip of the osteotome. However, later he would introduce a bone-added osteotome sinus elevation, where graft particles were added to help elevate the membrane further. So let's go over a few cases. Our first case is a 36-year-old healthy female seeking replacement of a missing maxillary first molar. Treatment planning, as always, prosthetically driven, starting with a restorative wax up for top-down planning. CBCT evaluation on the right showed about 6.5 millimeters residual bone height, as well as a thin Schneiderian membrane and relatively dense bone for the posterior maxilla. So given all these findings, this fit well for a crestal approach. Treatment plan was to gain 2 to 3 millimeters vertical height using osteotomes with a simultaneous implant placement. First step in this technique is to accurately determine the distance from the crest to the cortical sinus floor. In this case, pilot osteotomy was used through a surgical guide to about 1 to 2 millimeters short of the sinus floor. And then from there, osteotomes were used to gradually widen the osteotomy. In this case, we used a number 2 and a number 3 osteotome. And I think the key concept in here is tactile feedback. As the osteotome advances through cancellous bone, the feeling is relatively springy. But when the cortical sinus floor is reached, there's a more distinct hard stop. Gentle malleting then creates a green stick fracture of the sinus floor, allowing the cortical plate to be displaced superiorly while maintaining membrane integrity. After infracturing or upfracturing the sinus floor, graft material is incrementally introduced in small increments. The important principle here is they're not physically pushing the osteotome into the sinus cavity. Instead, these graft particles are mechanically elevating the schneiderian membrane. This aspect of the technique or this concept was refined in the modified osteotome technique by Devarpana in 2001. Some modifications in this technique was use of rotary shaping drills early in the process in areas of dense bone, as well as the use of a collagen membrane as a shock absorber on the end of the osteotome prior to the first osteotome being inserted. So at this point, the implant is then placed simultaneously. In the Summers technique, they used press fit implants, and we used tapered 4x10 ZimV full osteotype implant. Another advantage to this technique is bicortical stabilization with engagement of both crestal and the elevated apical cortical bone. In this image on the bottom right, we can appreciate a well-defined dome of new bone at the apex of the implant. So this brings us to the next question. Bone or no bone? Do we need to add bone? There's a randomized clinical trial by Tsai and colleagues found that no significant difference in outcomes were found between osteotome sinus elevation with grafting versus no grafting at 3 years. All these implants were placed into sinus with residual bone height about 4.5 millimeters, and then placed an average of 4 millimeters into the sinus. About half of them were placed with bone graft and half without. And they found in the grafted group, the initial bone gain was about 5.5 millimeters at 6 months, and then it was reduced by about half over the first 3 years of remodeling. The second group, the non-grafted group, had spontaneous bone formation of about 3 millimeters at 3 years. So both these groups, at the end of the 3-year study, wound up with about 3 millimeters of augmentation. So this suggests that simply elevating the membrane and allowing blood clot stabilization may be sufficient to stimulate new bone growth. So the Summers technique and slight modifications have a track history of predictability, but there have been some alternatives or advancements developed over the years. But the principles remain the same: elevating the sinus atraumatically through the crestal osteotomy. We talked a little bit about modified osteotome techniques. There's also there on the bottom left, Salvin osteotomes with stoppers to set the depth required. There's also osteodensification techniques, which Dr. Clark will talk about shortly. There's other rotary systems like DASC, ZimV, Meisinger. There are piezo-assisted protocols, as well as hydraulic or balloon-assisted elevations as well. All these alternatives are aiming to reduce malleting, improve tactile control, as well as potentially lower complication rates and perforation rates. So this brings us to our second case, 55-year-old male seeking implant placement at site number 14. Medical history generally non-contributory, but he did report a history of vertigo several years prior. Because, as we talked about, osteotome malleting can potentially trigger vertigo, we opted for an alternative crestal approach. Here we have the CBCTs, show about 5 millimeters of residual bone height, as well as our planned implant placement. We have a Schneiderian membrane uniform thickness of about 1.5 millimeters. So this is setting up for a favorable crestal approach. But instead of osteotomes, we used the ZimV crestal sinus lift kit. One of the major advantages of this kit is that it utilizes these depth control stoppers, which can allow for precise advancement and minimize risk of overpenetration. So our osteotomy was prepared just shy of the sinus floor using a 2-twist drill. From there, instrumentation was advanced in 1 millimeter increments using this stopper system. This allows us to have controlled sinus floor penetration while preserving membrane integrity. And we're increasing our depth as the floor of the sinus, as we're reaching the sinus floor. Skip this slide. And these drills are designed to cut along the sides to create this osteotomy, and then a non-cutting apical tip to lift the membrane atraumatically. Here we have the depth gauge, which is utilized to verify upfracture and to check depth by hanging the end of the gauge within the sinus wall, which you can see on the diagram on the right, as well as initiate sinus elevation circumferentially around the osteotomy. After penetration of the sinus floor, we placed graft material, and then always in small amounts so as not to overfill or clog the osteotomy. And then the bone condenser in the middle figure was set with a stop to precisely go to the level of the sinus floor. And we're not trying to get instruments penetrating the floor, just trying to push graft materials apically. And a spreader was used based on the osteotomy diameter and run at a slow speed. It's gradual expansion. It helps elevate the membrane atraumatically while maintaining tactile control. And this pushes the graft laterally and apically, so not localizing the force of the advancement in one small area of the membrane. Here we have implant was placed approximately 25 Newton centimeters, final insertion torque. Modest primary stability, so this was staged with cover screw and obtained primary closure. So we were able to place simultaneously, but loading decisions should always be based on primary stability. I'll turn it over to Dr. Clark.
All right, so this next patient is a 41-year-old male with a non-contributory medical history, referred to our clinic with the chief complaint of, I want an implant to replace my missing tooth. The patient reported that number 14 was extracted over 15 years ago, likely due to extensive caries. The residual ridge has both horizontal and vertical bone loss, with an adequate band of keratinized tissue present at the site. All right, these clinical photos demonstrate buccal and occlusal views of the site, and as you can see, there is pretty noticeable ridge resorption, both in the horizontal and vertical directions. And then here's a periapical radiograph at the site, again demonstrating a pneumatization of site number 14. Okay. Skip my animation. All right, good. So we captured a CBCT for the purpose of implant planning. The residual ridge height was measured at slightly above 6 millimeters. The Schneiderian membrane appears thickened, but as we learned earlier from Dr. Galliani, that could just be an overestimation from the CBCT. All right, the implant planning was done in conjunction with the restorative provider to facilitate placement of the planned 5 by 10 millimeter full osteotype tapered certain implant. A sinus lift of about 4 millimeters was required. A few features of the site here that we're looking at make it well suited for a closed sinus lift. There's more than adequate residual bone height with over 6 millimeters, no visible septa present at the area, and the implant is also planned at the lowest portion of the sinus, which allows for a lift with minimal tension applied to the Schneiderian membrane to hopefully reduce our risk of perforation. To accomplish our sinus augmentation goal, we elected to use the Densa-Burr kit for this case. This is an osteodensification system made by the company Versa. All right, so a little bit of background on this system. I wanted to give a little literature backing. All the studies listed have the or use DENSA burrs to perform closed sinus lifts. The first study by Orth found an average lift of 3.4 millimeters was achieved. Implants had a 97% survival rate, and perforations happened just under 5% of the time. The study by Mazur looked at sinus perforation rate, and they found it to be about 7.31%. Another study by Gaspar et al. Found closed sinus lifts to have a similar success rate to lateral window open lifts as long as you had at least 4 millimeters of residual bone height. And additionally, these cases, patients reported shorter procedure times and less postoperative pain. And then the last one listed was a retrospective study by Dr. Hawais et al. Found that the implants had a 5-year survival rate of 97%. It's important to note that Dr. Hawais is the founder of Versa and creator of the DENSA system. So just want to point that out. But overall, this system has been demonstrated to be very effective at performing closed sinus lifts. All right, so when performing osseodensification, you can use this system with a wide variety of implants. The recommended drill sequence is based on whatever implant system that you choose. If you go to their website and look through the IFUs, you just find the correlating recommended drill sequence. So, for example, if you're going to do a 5 millimeter osteotype tapered implant, you would use this sequence for osseodensification. All right, and then also in their IFU, there's a few different crestal sinus lift protocols listed, which are in general based on the amount of residual bone height that you have at your site. In our case, we had 6 millimeters of height, as well as 4 millimeters in width. So we opted to use protocol 1. These burrs should only be inserted up to 3 millimeters beyond the sinus floor. So unlike the previous systems mentioned, these actually do go beyond the original sinus floor, but no more than 3 millimeters. In our case, since we need 4 millimeters, particulate bone graft is recommended when trying to achieve a lift of that much, which is what we did in this case. So let's go ahead and get into the case here. Following adequate local anesthesia, we did a papilla-sparing paracrestal flap at site 14. Used a 2 millimeter twist drill as a pilot drill, advanced to approximately 1 millimeter shy of the sinus floor, which was confirmed radiographically. So as with the previous methods that were seen, this is to kind of thin it out and get close to the floor to facilitate up fracture of that floor. The DENSA burrs were then used in osseodensification mode, where they're run counterclockwise to get the necessary lift. So instead of cutting, these flutes are then compacting the bone in the osteotomy. You start with the smallest burr in the sequence and advance it all the way to that dense floor, which you do get that tactile feel of a hard stop. The next size up in a full increment, you pump into the osteotomy to get that up fracture. The burr is then advanced beyond the floor in 1 millimeter increments, taking care to not advance more than 3 millimeters beyond the floor. Once you reach that 3 millimeter lift, then you incrementally pack bone allograft or freeze-dried bone allograft in our case into the osteotomy and use the burrs to push it apically in small increments. So you can see here when comparing the apical depth of the depth indicators in these photos, you can see the one on the left. There would be a few millimeters of the implant showing versus post-sinus lift on the right. You can see how much advancement we got there using just the DENSA burrs. So the sinus lift was confirmed radiographically as there's radiopaque bone present around the apical portion of this direction indicator. At this point, we opted to place the implant. The implant was advanced to the desired depth, getting an insertion torque of about 45 Newton centimeters. The apex is seen to be beyond the cortical bone of the sinus floor here. Now we did kind of lose some buccal bone around the collar of the implant, as well as just a thin buccal plate in general. So we opted to do buccal onlay grafting here using FDBA and an OsseoGuard collagen membrane. For this reason, we opted to two-stage this implant. And then close the flap with 4O PTFE sutures with some simple interrupteds. And then here, just one more radiograph with of a better angulation to see the more than adequate sinus lift achieved. Right about there. So plenty of bone. Right. And then we got some references here. And there's our whole team. So thank you all for your attention.
Do we have one more?
All right. Can you guys see my screen and hear me okay? All right. I see thumbs up, so we'll get going. So it's an honor and privilege presenting to you all today. On my favorite actually procedure to perform, ended up doing one of these today, a direct lateral window sinus approach. So I'm going to be presenting not only on the approach, but really focusing also on prevention and managing complications as well. So we'll dive right into it here. This is our guide for the presentation. Again, we're going to talk about complications, talk about case selections pretty heavily, and then go into the surgical techniques with a few cases. Couple of the cases being complications, and then we'll briefly touch on post-surgical considerations at the very end. So complications for direct sinus elevation usually results from poor diagnosis. You can miss pathology, underestimating sinus anatomy of the case as well. For this presentation, we're going to focus more on the diagnosis and patient selection versus other variables, as well as the techniques, of course. Testori and many of his esteemed colleagues orchestrated a paper directing how best to avoid complications, which I think many of you have probably reviewed in your programs. That came out in 2022 regarding maxillary sinus elevation. The paper, you don't have to read these charts here, but if you do review the paper again, they do offer a couple of charts as well as checklists on trying to minimize really the chance of complications down the road before intraoperatively and preoperatively. So the authors emphasize sinus augmentation is predictable with excellent implant survival, but you want to make sure that you look at the CBCTs, don't miss a pathology, and don't underestimate the complexity. So there's a complexity score that they give, a simple, moderate, and difficult, as you see on the right side there. Different points, you kind of tally up the points based on the criteria, and again, the more points is more difficult. So a healthy dental patient is not always a healthy sinus patient. Patients should be screened for chronic sinusitis, allergies, nasal obstruction, mouth breathing even, respiratory disease, prior sinus surgeries, smoking, pressure sensitivity, if we have flyers, of course, in our midst, and or diving. Smokers have an odds ratio of about 5 times for perforations to occur, based on what Schwartz found. So ENT screening when symptoms or pathology are present is strongly recommended. And importantly, when you have acute sinusitis, after the infection is treated, the surgery is typically delayed for about 30 days. The most important radiographic structure to evaluate is the osteomeatal complex, the OMC. Since sinus drainage patency is critical for postoperative sinus health, mucosal thickening alone is not necessarily a contraindication. Mild thickening under 3 millimeters without any symptoms, you can typically proceed with treatment as long as there's a patent OMC. However, OMC obstruction, complete sinus opacification, or large mucosal thickening over 4 to 5 millimeters, foreign bodies, and any suspicion lesions, again, should be a prompt referral to the EMT. So wide sinuses with healthy membranes and no septa are generally straightforward, but in contrast, narrow V-shaped sinuses dramatically increase membrane tension and perforation. Cho reported perforation rates approaching about 62% in sinuses with angles less than 30 degrees, compared with nearly zero in wide sinuses over 60 degrees. So low residual bone height as well, below 4 millimeters, as we kind of touched upon already, increases technical difficulty because the membrane has to be elevated a greater vertical distance, increasing tension and reducing control during the medial wall elevation. So at the same time, primary stability, of course, can lessen with a smaller ridge. So sinus septa are among the most important anatomic risks. It's one of the highest causes of perforation. They occur in approximately 30% of sinuses, or septas occur in approximately 30% of sinuses, and most are buccal palatal, but some can present in a mesiodistal fashion, which makes navigating over those septa much, much more difficult. Septa tether the membrane, create stress concentration points, limit mobility, and obstruct instrumentation. So the membrane most commonly tears around these septas. A large septa over 6 millimeters and multiple septa substantially increase the surgical complexity. So membrane thickness plays a major role. Again, we touched on this, lower risk around 1 to 5 millimeters, which is normal. Conversely, thick disease membranes over 3 millimeters often represent a chronic inflammation and reduced elasticity when trying to lift the membrane. Testori describes these membranes as gelatinous and weak. And so really, really thin membranes on the opposite end of the spectrum are also can have higher perforation risk as well. So according to the International Team for Implantology, a residual bone height of about 6 millimeters or less should be considered for direct lateral window sinus lift. From here, residual bone that's less than 4 millimeters is typically a two-stage approach. So doing the sinus lift first and then going back to place an implant is recommended. A one-stage approach is that range, the 4 to 6 millimeter range, as far as the ridge width and dimension. So as far as surgical instrumentation goes, a direct sinus lift can be done with a high-speed handpiece and a round burr, traditionally speaking. A piezo helps to protect the tissues a little more and can also be used to prepare your window. Most commonly in our program, we use the DAS kit, the Dentium Advanced Sinus Kit, which utilizes dome-shaped diamonds and special instrumentations to carefully lift the membrane off the sinus floor. So let's dive right into our first clinical case. This is more of a straightforward case with the simultaneous placement of the implant. So one stage is more straightforward, only scoring about 4 points based on the Testori's criteria and checklist risk of modifiers. Anything under 8 points, again, is considered simple. Take this with a grain of salt, though. Just because the score is low doesn't mean that it doesn't guarantee success. So we're going to move on to the incision design, where we went mid-crestal incision across dental site number 2 and 3, two vertical releasing incisions at the site number 2 distal and number 4 mesial. So one can decide to leave the papilla intact if you want when making the incision, or making a C-shape hockey stick incision to leave the papilla behind. Upon reflection, you can appreciate the ridge compared to the depression apically where the lateral wall of the maxillary sinus lies. The DAS kit was utilized to prepare and refine the window again. And then Schneider membrane was reflected off the sinus floor with those instruments that you see right in the middle. And this is where you need to definitely take a lot of care, initially speaking, so you don't want it right out of the gates to cause a perforation. So again, you can see full elevation of that membrane. And then moving on to our osteotomy, I placed a collagen plug to protect the membrane just in case a drill might touch the membrane to prevent perforation. So you can see the osteotomy there. To increase the angiogenic potential and improve handling properties, sticky bone is made by mixing up minced LPRF and IPRF and bone graft material together. The bone graft mixture that we use in this case was 70% FTBA mineralized, and then 30% demineralized freeze-dried bone allograft to take advantage of its bone morphogenic proteins presence. So PICOS recommends a 50% bio-os and a 50% FTBA and tries to incorporate some autogenous bone graft scrapings as well. So you can opt to use that. So bone was placed. It's important to place the bone before you place the implant, so you don't have to navigate around the implant. So place it along the medial wall, anterior, posterior, all the extents before placing the implant. Here, 4.3 by 11.5 Nobel replaced tie unite implant was placed, about 1 millimeter subcrestally. So the remaining sticky bone was placed to fill the rest of the space around the implant, as you saw before, and then a resorbable BioGuide collagen membrane was used to cover the window. There's evidence to show that the increase in amount of vital bone formation occurs when a membrane is placed over the window before closure. So glycolon 5O and 6O sutures were used to close the flap, and you can kind of see the healing abutment there. And then here are photos showing progression from initial presentation to fully restored. And then here's a pre-op radiograph before sinus augmentation, as well as the final healing and bone around the implants at 19 months. So you can see the kind of bone volume around that that persisted again about 19 months there. All right, so surgical complications. During the surgery, definitely complications can occur. And again, there's different risk modifiers that this story talks about. However, the most seemingly straightforward case, however straightforward it can be, complications can arise during surgery. So most common intraoperative complication we covered, again, is perforations, but you can also have hemorrhage and then obstruction of the ostium. If you graft too high, or again, if the Schneider membrane is really thick and you push that higher to cover the OMC, that can cause obstruction. So transection of the anterior, the AAA is not life-threatening. The vessel itself actually typically self-contracts back into the bone. You are going to have a lot of hemorrhaging and the visibility might be impaired. And so you do need to deal with the bleeding. Electrocautery is a last resort due to compromised healing and remodeling. Instead, hemostasis can be achieved by pressure with moistened gauze, or bone wax can be applied, but bone wax has to be removed later on. So again, perforations, typically a size that's less than 10 millimeters is you can proceed with treatment. It's recommended anything larger than 10 millimeters. And a membrane that you can't stabilize is recommended to go to its 2-stage and just graft and do an implant later. PCOS is a little bit purports that you don't have to abort any procedure. However, PCOS has done over 2,000 sinus lifts. And as we gain experience, I think we can gain that confidence that PCOS does. But typically speaking, anything over 10 millimeters, we've done a 2-stage and kind of aborted. So again, you can kind of see the size there, but also the location of the perforation matters, and the ability to extend past your window when you're trying to do repairs, and the reflection is also important. And Fugosato has a well-known article that talks about the different locations of these perforations. So different approaches to repair. There's a Loma Linda pouch technique where you make an entire pouch that encompasses and covers the entire floor and even externally comes out, as you can see on the picture on the left. Picos doesn't like to cover the floor because he feels he can get good containment on all the other sides, anterior, posterior, superior, and out the window. He likes to also tack outside the window. You can also place holes inside of the around the bone margins and suture the membrane in place as well. That's been known to work. So here's a case of a sinus perforation, our next case. It scored also a pretty low point of 4 points. However, there was a perforation that persisted. So here, kind of looking at the initial photos here, initial incision design, again, release, you can see the kind of the difference of bone on the ridge and up higher where the sinus is. The DAS kit was used for the window preparation and then initial membrane reflection. And then a perforation occurred due to an irregular sinus floor. And so this perforation was greater than 10 millimeters, as you can see there. You can't see the extent of the perforation, but it was larger. So PICO suggests laying an LPRF membrane first to cover the perforation before placing your collagen membrane into the sinus, which was performed here. That kind of LPRF can be a little bit more sticky and help stick to the Schneider membrane. A 20 by 30 BioGuide absorbable collagen membrane was cut as far as the corners go, and then a portion of it that you can see that is meant to stick out outside of your window, and it was draped. So this is almost like a Loma Linda technique this resident used. Sticky bone was utilized for its growth factor mediated quicker healing, but especially it's great for its handling and binding properties, as we kind of saw in the first case as well. Sticky bone is less likely to cause bone extravasation due to most of the particles being bound to each other. So the excess portion of the membrane was then folded over to contain the graft and cover the window. And then another LPRF membrane was placed over the membrane window just prior to close to aid in soft tissue healing. A release was also made to make sure there's a tension-free closure. And here's the full closure using Cytoplast 400, a PTFE, and then resorbable glycolon 6 sutures. And this is 3 weeks after suture removal with no purulence. And overall, this patient, I believe, healed really well. And you can see the before and then after. Again, not deciding, kind of one miracle at a time idea. Decided not to place the implant because the perforation was larger than 10 millimeters. But you can see the bone graft nicely contained there. The last and final case I want to present is a perforation, but along with a severe post-operative infection. Kind of what do you do in those situations? So patient presented again with a simple score, but again, not take that with a grain of salt. But you can see all the modifying factors that this patient had on the right side. But the treatment plan overall was to extract the number 12 and number 13 and number 15, as well as number 12, due to non-restorability and severe caries. CBCT shows close approximation of root canal treated roots at the sinus floor, increasing the likelihood of sinus exposure. So this is a point that should definitely be looked at upon CBCT review. And then difficult extractions of the endodontically treated teeth led to a couple of large perforations for this resident, greater than 10 millimeters in size in 2 different locations. And then membranes, at that time, the bone was decided to be placed, and then the membranes of the for LPRF was not used for sticky bone, rather to place over the graft and before closure to aid in soft tissue healing. This plays into a part of just in a future slide you're about to see as far as the bone graft not being contained. But unfortunately, 2 months after the patient reported pressure, purulence, a bad taste from the mouth, and also clinical findings revealed a large amount of purulence, as you can see on the left side, emanating from the incision lines. Patient also expressed congestion in the right maxilla, or left maxilla, sorry. A new CBCT was taken, and you can see the graft extravasation and purulent buildup. A retained root tip was also identified during CBCT evaluation. Second here. Okay, so this is what was found upon re-entering the site. You can kind of see the membrane is a little bit more sclerotic and thicker. The provider aspirated the site with a syringe and set aside to send for culture. You can see quite a bit of purulence coming from the sinus. The membrane was intact around the perforation and later reflected circumferentially to make room for a membrane. And then instead of trying to graft again and then biting off too much that we can chew, and on this instance, a 30 by 40 Biomed Extend membrane was trimmed and placed to completely wall off the perforation. And so the resident did a really good job closing that perforation with that membrane. And then the LPRF membrane was placed over the collagen resorbable membrane, again to aid in soft tissue healing. And good tension-free primary closure was achieved with glycolon 5.0. Post-operatively, it's important to note the patient was given a 7-day course of Augmentin based on Testori's consensus recommendation, as well as PICOS. It's BID 875 and a 125 regimen. So here's 3 weeks healing, where the patient didn't complain of any pain or tenderness or congestion at this point. So finally, we'll cover some post-op instructions. Dr. Galliani covered some of these, but I'll go a little bit more in depth on some of the instructions here. One of the most important instructions is absolutely no nose blowing, since increased sinus pressure can disrupt the membrane repair, and it can also displace graft material if you try to repair any sinuses. Open mouth sneezing helps minimize pressure transmission. I also emphasize rest, reducing exertion, medication, compliance, of course, and soft diet recommendations to minimize swelling and postoperative complications. So chlorhexidine can be used. Analgesics, is a common combination, Tylenol and acetaminophen and Motrin. And as well as decongestants as needed. It's important to note Afrin nasal spray can cause rebound sinusitis or rebound congestion, sorry, if you use it more than 2 days, typically speaking. So just using as needed is important. So different signs, what to see as far as symptoms go. Although uncommon as far as post-op infections go, as we saw in the last case, warning signs should include increasing pain, swelling, erythema, purulent drainage, fistulation, flap dehiscence, or worsening tenderness. So prompt recognition and management is critical to preventing further infection. This is again Testori and Picos recommended as far as these sinus infection regimen. If you're pen sensitive, different from true pen allergy, he recommends cefuroximine, Axetel, or cefprozdoximine, Proxetel, and then levofloxacin and metronidazole for your true pen allergy. So main takeaways, evaluate the OMC. OMC is one of the most important aspects to the anatomy. The mild mucosal thickening alone is not necessarily a contraindication. And then narrow sinuses, septic greater than 6 millimeters, we talked about, increases surgical difficulty and perforation risk. But lastly, just want to drive this home. While the difficulty scoring system is helpful conceptually, kind of trying to stay away from really, I guess, severe presentation, experience and sound clinical judgment ultimately matter more than any numerical score. So tougher cases will become more manageable as we gain experience. So this can definitely change. So here are my references. And that's the team there. And yeah, so I'm going to turn this back over to Dr. Galliani, and he's going to run the question and answer portion, I believe.
All right. Thank you, Dr. Chung. And thank you, Dr. Thomas Betterbed and Cody Clark, for your presentations. Great job, everyone. I had just a couple questions. I'll start with the Navy presenters. Just using bone or not, you demonstrated that some clinicians not to use, and they not, but what type of bone do you use in your practice, as well as like, do you use any other kind of PRF or membranes that you may put into the socket with your lift?
We couldn't hear the beginning of that, but I think you're asking about putting bone or not in our closed lifts.
Or just what type of bone you prefer to use, or any other membranes or PRF, any adjuncts?
We want to use something that's going to show up in the X-ray, FDBA or BioOS. Typically, we use FDBA for ours.
Yeah, I mean, there are times where just, from the drills, we'll collect some autogenous bone and mix that in with the graft. And just for more complex cases, we might consider doing LPRF, making some sticky bone, or just getting membranes in there. So it's kind of a case by case basis. But for the most part, I'd say we use FDBA for the lifts, and that's typically if we're going more than 3 millimeters of lift is when we kind of employ that.
Okay, thank you. And then I want to just ask the audience, if you have any questions, just go ahead and put them in the Q&A section down at the bottom. But while we're waiting on questions, I wanted to ask Dr. Chung as well. So some clinicians will take their bone graft and mix something like a tetracycline or an antibiotic within the graft. Do you
Mhm.
perform this at all in the practice over there? And if so, when would you choose to do it?
So I typically don't involve mixing antibiotics with my bone graft and place them in the sinus as part of my practice. I know there's different literature that shows, or historically tetracycline has been used. I think just to my review and knowledge, as far as that being a strong delineator of huge, uh, I guess, benefit or improvement for bone gain. There's a lack of evidence from my understanding, but also tetracycline, once it's suspended in a solution, it's a little bit acidic. And so I guess the anti-inflammatory and kind of fighting the bacteria portion of my grafts, I like to use PRF for that reason, since it's leukocyte rich and helps out with the initial healing as far as the stages of wound healing, as far as inflammation goes. You have a lot of leukocytes there that help out with the initial healing.
Awesome. Thank you. And I'm not seeing any questions in the Q&A. If anyone wants to raise their hand for questions, we can take those. Um, Otherwise, if there are no other questions, I'll hand it back off to the AAP and Dr. Bain as well. And thank you all. Oh, see a question over here. Yeah. Okay, so the question is for you both. I'll leave it open, but do you consider placing mostly xenograft like BioOS for long-term volume stability because of bone remodeling? I'll start with Dr. Chung because you just talked.
Yeah, so that's always a consideration. The only part was, or the only consideration, or part of what I consider is if the ridge, for instance, was 2 to 3 millimeters and we're doing a two-stage approach. Later on down the road, you can place BIOS, and plenty of people do. Again, Picos's go-to is 50% BIOS, and then 50% FDBA and a little bit of autogenous. But as we know, the turnover of BIOS, it turns over very, very, very slow. And if you have a really, really thin ridge initially, and then initial healing, you have to wait. I would wait a little bit longer, so more like the 9 month mark to place the implant, because later on your implant's going to be reliant upon mostly grafted bone, rather than the ridge for really thin ridges. But certainly it's used, obviously in Europe. It's used widely, but intermixture with autogenous bone is really important from what I've seen with literature. Just BIOS alone doesn't perform as well as if you do not add autogenous bone.
And same for the Navy. Do you guys have anything to add regarding BioOS and your transcrestal lifts?
No, typically not BIOS for the transcrestal, but for open, some 50/50 FDBA BIOS typically.
Okay, perfect. Thank you both. So I'm looking in the chat, don't see any other questions at this time. So we'll hand it off officially back to Dr. Bain. And I wanted to just thank everyone for their participation, their viewership, and thank the AAP for hosting us again. Army, Air Force, Navy, little tri-service military here. We appreciate the opportunity. And thank you all for your time.
Yeah, thank everyone for attending. It was a great presentation, great content. Really appreciate the time and effort these residents put in. Y'all are doing great things in your programs and should be very, very proud. Again, we want to invite everybody to do the post Spark survey that Tamisha will send out. And don't forget, August the 11th is our next Spark. Please mark your calendars and don't forget to register for Arrive. Hope to see y'all soon.